Webinar. I welcome you all to our second webinar organized by this newly elected Council of West Zone Urology Society of India. And it is indeed pleasure to see all the friends here. And today's webinar is on interesting videos on RIRS. So we have an experts, 5 experts presenting various videos on various topics. And then the video presentation will be for 5 minutes. After that, there will be a discussion period of 5 minutes, which will be discussed with the speakers, along with our moderators, Dr. Nanjappa, as well as Dr. Abhishek Singh, and Dr. Sungcho will join us very soon. He's also even flying to AUA at this moment now. So he will also join us in a couple of minutes. And I, the convener of the program, will see that everything goes as smooth as it should go. And at the end of the program, I will make my final concluding remarks on each and every video. So again, without wasting time, I welcome you all. And I request Dr. Gaurang Shah, the Secretary of Urology Society of India, to make his opening remarks. And then I'll hand it over the mic or whatever you say, the program to Dr. Nanjappa and Dr. Abhishek Singh. Dr. Gaurang Bhai, please.
Yeah, thank you very much, Kandar. As the council had promised last time, we are continuing with our Zoom meeting. And it is very interesting that every month we are, picking up the new topics. And this time we are so grateful that our president, Dr. Kandar Parikh, who is supposed to be the one of the very well-known, urologists as far as the RIRS is concerned, and he has conducted so many conferences also. So I am sure this is going to be a very interesting seminar. Only thing I want to add is that the indoor, our meeting is coming very close to us. So I request all of you who have not registered, please register for that. And I will not take much time. And I'll request Dr. Kandar Parikh to start the session.
Thank you, Dr. Gaurang Bhai. I think this is already 8:06 and we are bang on time to start the program. So I request Dr. Nanjappa as well as Dr. Abhishek Singh to take over the charge of this program. And all of us will be listening to you as well as to the speakers. Again, my sincere request to all the speakers to please stick to the time so that we can have more time for the discussion. Okay, so Dr. Nanjappa, you can start inviting the speakers one by one, and then we'll have at the end of every video, we'll have a discussion. Okay. Mainly you and Abhishek will be asking the questions to the speakers. I will make my concluding remark at the end of the session. So Dr. Nanjappa, please.
Thank you. Thank you and good evening, everybody. Without wasting much time, let me call our opening batsman. That is none other than Dr. Hiren Soda, who is very good and an expert in flexible ureteroscopy working at SciFi. So he's going to tell us about the role of RIRS in a retained DJ stent, his experience with a video. Hiren, you can share your screen and you can start.
Thank you. Good evening to everybody. I take this opportunity to thank Kandar Parikh sir and the entire West Zone Council for this opportunity. I am going to present the role of RIRS in retained stents. We all know that most of the times the retained stents are basically due to a significant stone burden. But this is an interesting case because here this stent was being tried to retrieve without any much significant stone burden, but it had failed by 2 urologists. Patient had been referred to me. On going inside, I thought, let me start with breaking the encrustations. So here in this video, you see that I'm breaking the encrustations by just being on the surface of the stent. And then suddenly, to my surprise, I noticed that the stent is going from this calyx into another calyx. So this is a very interesting video wherein the cause of the retained stent was a badly placed stent or a forcefully placed stent. So this is something to learn from this video, is that we should never ever try to forcefully pull out a stent. and how the flexible has reduced. Here you can see at this part of the video that the stent is going through this calyx and going into the other calyx. So flexible ureteroscopy and now this is the video showing the stent in the other part of the calyx. Very closely observe, it is going through and through from here, and we'll show you the other end. It is going into the other calyx. You will see it very shortly. So here we are breaking the encrustations. And there, as we take an overview, you see the stent is going from this calyx into that calyx. From here it is going in. So retained stents in the past only could be retrieved by either doing a complex PCNL along with the ureteroscopic surgery. But in the last decade, we have seen the role of RIRS, how much it has made stone surgeries as well as this complicated situation very easy to tackle. Now, this is the third part of the video wherein after having a close examination and removing all the encrustations, we are sectioning the stent. And we definitely used C-arm to see that no part of the stent has remained in the system. So sectioning of the stent was done with careful removal of each part, the sectioned part and the part which was going through. And this is the last part of the video wherein the sectioned stents have been placed in one calyx. And then we have retrieved it one by one, making sure that the part going through and through the calyx has also been retrieved. So that was the retrieval of the stent. Coming to a quick short 2-3 slide presentations. This is the classification of retained stents showing the significant stone burden on each side. That is the X-ray classification of these stents. And retrograde ureteroscopic surgery is efficient and safe in removing retained stents and associated with stone burden. The various type of lasers can be used for these encrustations to be removed. Retention of ureteral stents offer due to poor compliance of patient is not uncommon in our population. If left untreated, retained stents can result in significant morbidity as well as mortality. Various treatment combinations have been used for retrieval of encrusted stents. However, with the advent of flexible URS technology, it is the most preferred endoscopic technique now. In patients with encrusted and retained ureteral stents, accurate determination of the proximal stone burden is very important using CT. It should be emphasized that plain X-ray should not be used as it can underestimate the proximal encrustation and lead to poor operative preparation, complications, and need for unanticipated additional surgery. A significant proximal stone burden greater than 100 mm stent should be correlated with the need for surgical procedures and surgical complications. Distal stone burden can be easily managed with cystoscopy as well as URS. Thank you.
Good presentation, Hiren.
Thank you, sir.
Excellent video. Can you just tell me that you always, you will combine the, as you said, the distal part of the stent has to be tackled by semi-rigid ureteroscopy first?
Yes, sir. Either cystoscopy or semi-rigid ureteroscopy, depending on how the encrustation is. If it is going into the ureter, definitely you will need a combination of cystoscopy with ureteroscopy. And then you must proceed along the stent and have a look throughout the ureter as well as the PCS.
Okay, so in this case also you used an access sheath for removal of the residual fragments in the kidney?
Yes, sir.
Okay, so is it easy to go by the side of a stent which is retained and you could not cut it into pieces with a flexible ureteroscope?
Usually, sir, the ureter is quite well capacious and dilated. Most of the times we also see that a semi-rigid also goes in very easily by the side of the stent. And after I retrieve most of the stent, then only I use the access sheet to retrieve the rest of the fragments from the kidney. safeguarding the ureter.
Abhishek, your comments?
Yes, sir. Sir, very insightful presentation, sir. Sir, a
Thank
few thoughts on this situation. One is,
Yeah.
sir, usually this is a typically a very unusual situation. So even when the stent migrates out of the kidney, which is a more common situation rather than it going from one calyx to the other, you
Yes.
can, on most of the situations, actually pull out the stent even when it is out. So
Yes.
this is one of the rare instances where probably there's a little bit of incrustation on both the sides of the stent where it passes from the calyx, and therefore due to the curvature it was not being able to.
Correct. And there was a complete coil. You saw the complete coil in this side of the calyx. The complete coiling had taken place. So
sir,
it was not easy to just pull it out, because on 2 occasions urologist had tried and then the case was referred.
Sir, as regards to this particular situation, we all are actually little wary of using flexible ureteroscopy because of the concerns of sepsis in this particular situation.
Right.
But there are situations where you can just not avoid flexible ureteroscopy.
Yes.
Like a completely encrusted stent or a ureter upper ureteric large burden upper ureteric situation. In this situation, it is very difficult to manage these things with a semi-rigid with PCNL.
Absolutely. As you do more and more flexible ureteroscopies, your comfort level with the flexible ureteroscope will become more than the semi-rigid.
Yes.
Actually, you will reach a stage wherein for even upper ureteric stones, you might start. I'm sure Kandap sir, Nanjappa sir, all of these experts here, they are also agree with me that upper ureteric complex stones are better tackled with flexible than with semi-rigid.
I think flexible ureteroscopy is pretty much the standard of care if you look at literature for managing upper ureteric stones.
Absolutely.
So, but one point that I was trying to drive at is now a significant burden of retained stents or stone with stents are also seen in patients who actually don't forget their DJs, but situations like retroperitoneal fibrosis, which are on treatment. And the ureter in these situations is pretty stiff. So when we are handling these patients, we should be prepared for a retrograde as well as antegrade flexible ureter.
Of course, in every situation, including this one, we have to be ready, and that is where the counseling comes in. That even though you have a flexible, there may be a time where you might need a conversion.
No, sir. I was saying that you should be looking for a antegrade flexible ureteroscopy.
Oh, yes.
You may have to enter the ureter. You might require PCNL on most of the occasions. That is perfectly fine.
Correct.
But you should also be ready to put in a ureteroscope percutaneously into the ureter.
I have done that in one case where a lady was born with the ectopia vasicae, and at the age of 28, she had a lower ureteric stone with a Cohen's cross-triagonal ureteric reimplantation. And I just couldn't enter the ureter, and I went antegrade and broke the stone in the ureter. It's a different situation, but where
there is one question. The
Yes.
earlier urologist, which method they had tried? They had tried only ureterinoscopy, or they had tried even PCNL?
Sir, it is most of the times combination of URS with PCNL.
No. In this particular case, anyone had tried?
They had only tried to retrieve the stent cystoscopically, because they said that the significant stone burden was not there. So to their surprise, why the stent was not coming out in spite of not being a significant stone burden.
Fine.
Just encrustations. If you look at the video, it is just encrustation. So the surprise was that it was going through and through the calyx, and that is what was holding the stent across.
Hiren, can you tell me what is the grasping device you used to take out the stent?
So in this case, I used an N-gauge basket.
Okay.
N-gauge basket. However, you do have flexible forceps from Boston that can be used, but they are more of the time biopsy forceps.
But it's not very easy to hold a stent with an N-gauge basket. That's why I said pulling out a stent appears to be easy because you're doing it, but actually pulling out a stent with the N-gauge, it's very difficult. And yes,
I think in this case, one can pull it out up to the upper ureter and then can use the rigid ureterinoscopy to
also. Sir, the Piranha is available from Boston Scientific, which can be used.
Because you're using an access sheet, putting a rigid ureteroscope up to there will be difficult.
Correct, sir.
You will have to do the whole procedure with a flexible only, because you have an access sheet in place. Yes, Kandar, any comments from you?
I thought I will make all the comments after the end of the session, which I'm going to tackle each and every video one by one. So I think right now both of you are doing a great job. So you please continue doing that.
Okay.
So, sir, can we just summarize? Between both of us?
Sure.
You can go ahead and summarize, sir, so that we give a small take home.
So the role of RIRS in retained DJ stents is what Hiren has mentioned, that it is specifically for the part of the stent which is in the pelvic calyceal system, but mostly not in the ureter. In the distal part has to be tackled with the semi-rigid. Always see that you tackle your infection prior to doing this procedure. Try to maintain an access sheath if possible, and always see that you have a low intrarenal pressures, and see that you cover the patient adequately with antibiotics, and of course use a good rasping device and try to complete the procedure. If not retrograde, then you should go antegrade. So you should always be ready for an antegrade thing. So I think that would be the thing for the role of flexibles in a retained DJ stent. So we go on to the next talk. I think Abhishek, you can invite the next speaker.
Thank you.
Thank you, sir. It was a wonderful demonstration, sir.
Thank you.
Going ahead, I would invite Dr. Ravi Jain, who's a consultant urologist at Ahmedabad, for his talk on difficult RIRS in large burden stones and difficult anatomy.
Yeah. Am I visible and audible?
Yes, please go ahead, Ravi.
Yeah. Thank you, Vezon Council President.
Sorry,
sir.
Ravi, I'm interrupting. I'm really sorry.
Yeah.
I would request all those who have joined us to put in their comments and questions in the chat section. We can take it up so that, we can ask those questions. So we request, there are so many people already joined in, almost 79 to 80 people. So requesting all to put your comments and your questions in the chat section so that, those questions can be answered. Whatever can be taken up just at this session. Continue, Ravi. Sorry to interrupt you.
Thank you, sir. Thank you, Vezon Council, President, sir, Secretary, sir, Nanjupa, sir, and all the faculties for giving me this opportunity. And I shall be talking on the role of RIRS in difficult RIRS in a large stone burden with a difficult anatomy. To begin my case, the case was RIRS for a stone burden more than 4 centimeter with multiple stones in the lower anterior calyx and long infundibulum. As you can see, the patient had bilateral stones on the right and the left side. And on the CT scan report, the patient had multiple obstructing stones on the left side. The stone burden was more than 4 centimeter. The patient presented with AKI and he was stented outside for urosepsis. When he presented to me, I first did a right RIRS and bilateral DJ stents were placed. And despite a pre-stenting, the patient, I had difficulty in placing the ureteric access sheath. So I had to go for a sheathless RIRS in this case with a disposable digital urotoscope. The patient had on the NCCT KUB, I didn't have a picture of the anatomy, so I did an RGP and was surprised to see a very long infundibulum in the upper calyx, a bifid pelvis, and a long lower anterior calyx. The patient had lower ureteric and mid-ureteric stones, which I started tackling with the semi-rigid urotoscopy. And after doing the semi-rigid urotoscopy, then I proceeded for the flexible urotoscopy. So this is the video of the semi-rigid urotoscopy I performed. Now, started tackling the stones in the kidney. To begin with, this was the upper calyx stones, which started dusting with the help of thulium fiber laser 35-watt machine and the disposable digital urotoscope. And since I didn't have a CT IVP, I was not aware of the anatomy. And this was a surprise to me. The patient had a very long infundibulum of the upper calyx. As you can appreciate, the patient had a very, very long infundibulum upper calyx. And now I've started dusting the pelvic stone. Usually the settings I prefer for the dusting, I usually start with the 0.6 to 0.8 joules and a 10 to 15 hertz frequency. And during the intraoperative period, I play with different settings, which help me in giving a fine golden dust with the procedure. The patient had a bifid pelvis, and now after clearing the pelvic stone, I shall be going towards the lower calyx stone. Here, in the lower calyx also there are multiple stones, and I'm trying to bring the stone, migrate them into the upper calyx, so that later on I can clear them in the upper calyx. Now, in the lower calyx, there are multiple stones. See, there was one stone which was dusted over there. There is another stone in the lower calyx, which also I'm trying to bring out into the upper calyx, and I'm dusting it there. So the angle of the lower calyx was the difficult part, and a few stones in the lower calyx were at a very difficult angle. So this stone I was able to bring with the help of the laser itself. I didn't need to use the basket, and I'm dusting the stone with the thulium fiber laser. Thulium fiber laser has been excellent in the dusting as compared to the holmium YAG, and gradually the stone thresholds have started to increase with the help of the thulium fiber laser. Now there is a stone which is situated at the 5 o'clock of the calyx, and my laser fiber is projecting at 11 o'clock in this particular digital disposable ureteroscope, and I'm having a tough time in trying to focus the laser at the stone. I'm not able to focus the laser despite multiple attempts. Then I thought that I will basket the stone, but when I used an engaged basket, even that was not possible. I was not able to hold the stone, grab the stone. Finally, I used a nitinol tipless basket, a zero tip basket. And with that, I'm able to basket the stone into the upper calyx. So once the stone is basketed into the upper calyx, my flexible scope, with the help of the flexible scope, I can go and dust the stone over there. Once the stone is basketed into the upper calyx, it is easy to dust the stone and give a good clearance. At the end of the procedure, the fine golden dust was visible. The flexible ureteroscopy time in total was around 1 hour and 15 minutes, and the laser dusting time was close to around 40 minutes. This is the preoperative X-ray KUB, multiple stones in the left kidney. And after 1 month, I got a plain CT scan as well to see the clearance, and there was no clinically significant residual fragment. That was a complete clearance in this procedure for a large stone burden case, and the patient had mild fever, but which resolved after antibiotics, and the patient was discharged on the postoperative day 3. To summarize, RIRS is ideal for multiple stones. Now with the help of the thulium fiber laser, and long infundibulum calyx was the difficult part. Thank you, sir.
Very nice presentation, Dr. Ravi.
Thank you, sir.
I have a few questions.
Yes, sir.
In the contemporary times, what should be the definition of a high burden stone disease? Because oftentimes what happens is that we are just looking at one dimension and then calculating on 2 dimensions.
Yes.
So what should we consider as a really a high volume?
Yes. So I feel the number of the stones and the cumulative stone burden should be taken into account. A single stone with a diameter of more than 2 centimeters as compared to multiple stones with a diameter of 1 centimeter, maybe 3 or 4 stones. So like in this case, there were different stones of 10 mm, 11 mm, 9 mm. So that cumulative stone burdens, especially located at different locations, is the difficult part. These days we do not get those stagon stones, but when we get stones in different locations, so these should be the high burden. So anything more than 2.5 centimeter should be a high burden stone burden.
I would also say that calculating the volume of the stone and then averaging or cumulative volume of a stone would be very important thing. Anything more than 1,000 should be considered that it's going towards high volume, and definitely more than 1,500 is a significant volume. So that gives a sense that obviously if this case we would have calculated the volume, it would definitely have been more than 1,200 or so. But that would be a very good idea. Another question that came to my mind is that when we look at here, of course, you did not have a preoperative initial anatomy, but when you have it upfront, then do you use the conventional arithmetic to decide whether you will actually go into the lower calyx? And for the benefit of the audience, can you just bring about the nuances of the lower calyceal anatomy if I were to decide to go in or not go in? Is
Yes.
the characteristics that you would use?
Yes. Sir, the lower calyx angle especially would be the important thing. The second important thing will be the infundibular width. And the third important will be the ratio of the calyx angle and the infundibulum. So sometimes the CT-IVP gives a deceptive picture as compared to the RGP. So few times we feel that this might not be a possible case. So we always, as in this case, I had explained for a staged procedure. I had explained for a consent for mini PCNL if required, especially for the 5 o'clock stone, which was difficult. So lower calyx angle, infundibular width, and this should be the important parameters.
Ravi, will you anytime consider supine PCNL with RIRS?
Yes, sir. In selected cases, supine PCNL with RIRS like ECRS should be the
in
modality.
In this case, what do you think? It would have been more beneficial, or this was better?
Sir, in this case, I was able to deal with the system. I didn't have an idea of the RGP. So when the long infundibulum, I was expecting a stone burden to be large. He was a stented patient. So I was expecting that I might need a second stage. But with the difficult angle and the anatomy, yes, putting ECRS into mind should have been a consideration if I was aware of the anatomy.
So I think that is a very, very important point that Gaurang sir has just brought about, that ECIRS is a good option. And this is one of the really a good indications for ECIRS. And your point is also well taken. If the pelvic ileal anatomy was known beforehand, then it would. Another point that I wanted to bring about that regarding this whole discussion regarding the infundibulopelvic angle, and earlier we were talking about the angles which were like 45, 60. Now the last meta-analysis by Somani and group, now that says that about 38.5 degrees is a critical angle. So their meta-analysis, so this has probably changed the way that we look at the angle. The really acute angle is something really less than 38.5. And with the modern armamentarium, we can definitely go into anything which is 45, 50. Possibly experts can even go into things like 30 degrees. But 38.5 is what is a textbook cutoff.
I would just add one point that with my experience, I have felt that lower anterior calyx stone is the most difficult. Even in lower calyx, posterior calyx, sometimes when in the lower anterior calyx, the whole hand, the whole position of the hand is something like this, that I have to rotate the wrist completely and do a procedure. So I have found in selected cases, the lower anterior calyx stone is one of the most difficult cases. That is my opinion.
See,
please summarize. Yes, sir.
Yeah, so I would also like to put it that when you do RIRS in a large volume stone, we should be very careful that we are not treading beyond our guidelines, but we are confident enough to finish off the procedure in a sitting, and we are not going to stage it into multiple sittings. So unless your other procedures are contraindicated, we should start treading into the field of doing RIRS in large volume stones. Now, when you're going beyond your guidelines, you should be sure that you're going to finish off the case in a sitting. Otherwise, we would give a wrong message to everybody around here that you can start doing RIRS in any burden. So first important thing is your experience. So how much experience is? So you should not start doing flexible ureteroscopies in large burden at the start. So that is one important thing which I want to say. Secondly, when you're doing these large burden stones, you will see to have that if you're going to do the dusting procedure, so many times you get lost in the system, because here you have done multiple stones. Actually, this case which classical you said, I think Ravi would be, the next person would be the right person, but it is definitely more than 4 centimeters is a definite case, which is a large burden here. So here we will have to see which stone we tackle first, whether we tackle the smaller stone or the larger stone, because sometimes when we do large burden stone, there's so much of dust that the rest of the fragments are buried below this dust. So you must have experienced that, Ravi, so many times, right?
Yes, sir.
So what do you do in this
flexible ureteroscopy at the start of the procedure, go into each and every calyx before I start dusting, so that as you rightly pointed out, sir, that a smaller fragment is not lost in the dust. So before starting the dusting, I go inspect each and every calyx, make an impression in my mind. Okay, this is a stone lying over here. This is a stone lying over here, so that sandstorm doesn't bury my stones.
So that's very good when you have stones in multiple calyces. But if you have a large bulk in the pelvis and you're doing that procedure because PERC was contraindicated in that patient for some reason, then you will have this challenge of having the fragments getting lost over there. So that is one more thing. The thing with Abhishek pointed out of working in the lower calyx, definitely here, your working channel, I mean, where your position of your working channel is also very, very important. And whatever points he mentioned about infundibular width more than 5 millimeters, length more than 3 centimeters, or an angle less than 45 degrees, I think these things are very difficult to measure on. Actually, when you go to see a IVU and you start measuring it on your CT IVU, there are a lot of differences of how to measure the IPA angle itself. There are a lot of options. I think, Abhishek, you must be knowing that IPA angle is so difficult to measure because we don't know which angle to exactly measure. And what you exactly see on an IVU may be totally different actually when you go in. So these are guidelines which will help us to see whether we should go or no. But actually in the procedure, when you go inside and take your scope in, this would be a right way to go about for the lower calyxal stone. I think that's lovely presentation, Ravi. So I think we should proceed further, Abhishek.
Nanjappa, can I speak?
Sure.
Yeah. Nanjappa, it is very easy to measure all the angles and all the volumes and everything if you start looking at the DICOM file per se and stop looking at the CT films. For last 5 years, I have stopped looking at the CT films. I directly work on the DICOM files. It's very easy. You can calculate the stone volume. You can get all the angles, confident, everything. And that makes our operative planning fairly easy and straightforward.
Sir, it is easy, but it is not consistent. That is what the challenge is. I think that is what sir was. I agree that when you do it yourself, you may be able to do it, but it's like using an ultrasound. Everybody might have different coordinates to judge on, and between 45 and 50 there is hardly any difference. So I would for somebody I would choose a flexible ureteroscopy, whereas you might choose a PCNL for the same thing. So there's a lot of individual variation in measurements. That is what I think he was trying to.
Yeah, I just wanted to say, Prashant, that what we measure and what we actually come across during the procedure is totally different. So we should have a, sometimes you see the length of the calyx, you feel that the narrowness of the calyx, you feel that you'll not be able to enter, but actually when you go ahead and put your scope in before you take the patient for a perk, easily you'll finish off the procedure by doing a flexible. This is what I meant by saying that you'll not be able to.
Yes, Nanjappa, it happens with you. Whenever you want to go there, your scope goes there. That's why you are Nanjappa.
Okay, thank you.
But sir, you brought out a very important point that it's gone out those days that we rely on films. We should get one CD, open it in a DICOM reader, and just go through whatever you are doing, stone, malignancy, whatever. So I think that's a very important point. Sir, Nanjappa sir, can we move ahead, sir?
Sure. There's one question by Dr. Gite. It's better to have an anatomical roadmap Hounsfield unit before going for RRS by doing a CT IVU. So Dr. Gite has asked this. So what is Ravi? Every time do you do a CT IVU before going?
I will prefer to do a CT IVU. I will prefer to do a CT IVU. But here the creat was elevated and he was in AKI. So I didn't have the chance to go for a CT IVU.
So if you don't do a CT IVU, do you do a contrast study before your procedure?
Yes, sir. If I don't have a CT IVU, I would prefer to do a contrast study RGP to have a roadmap ahead.
Okay. So we can proceed, Abhishek.
Yes, sir. So going ahead, I would now invite Dr. Ravi Nagar, sir, for his talk on RIRS in multiple renal calculi. Sir, over to you, Ravi, sir.
My screen visible?
Yes, sir. It's full screen now. Please go ahead. You're audible.
Yeah. Good evening, everyone. I would like, first of all, I would like to thank West Zone Council as well as the office bearers for giving me an opportunity to do this presentation of an interesting case in which RIRS and multiple renal calculi. Here is a bit summary about the case. 46-year-old gentleman who is a non-diabetic presented with flank pain. He had a history of open pyelolithotomy on the right side, which was done around 10 years back, and a history of PCNL on the same side. He had some eventful course post-operatively in PCNL with a lot of hematuria or something. The papers were not available, so he was a bit more skeptical to go ahead with PCNL for a surgery. USG abdomen for this patient revealed mild to moderate hydronephrosis with multiple calculus of size varying from 8 mm to 14 mm. And his blood biochemistry was normal serum creatinine, and his urine culture sensitivity showed no growth before the procedure. His non-contrast as well as the contrast CT IVU which was done showed multiple stones in the pelvic ileal system. They were around 4 in number. And in contrast, there was prompt function with some artifacts around the kidney, maybe post-operative changes which were seen. The kidney anatomy on the right side was also a bit distorted, and the calyceal anatomy was a bit changed, maybe because of the previous surgeries which he had twice on this side. I took this patient for RIRS only. When I just passed in a guide wire and did an RGP, I saw a lot of filling defects into the pelvic ileal system. And as a rule, when we do a rigid URS before RIRS, I saw some putty-like material or some soft tissues-like material present in the ureter as well as in the pelvic ileal system. So I just tried to stage the procedure. I stented the patient and took urine culture samples from the renal pelvis as well and stented the patient. After around 14 days of interval, this thing I again prepared after the urine culture was seen negative. Once again, it was negative. So I did RIRS again on the same side, right side. The stent was removed. I took a 12-14 French excess sheath, which went in quite easily because the patient was stented. 9 French scope, digital flexible scope was taken, 60-watt super pulse thulium fiber laser, 200 micron fiber, and manual irrigation with 50 ml syringe. This is the video of this. When I went inside, I saw a lot of this putty-like material or soft tissue-like material enveloping around the stones and which was just covering the stone. So I just removed that thing by the laser and went on the stone by removing it off and then dusted the stone in non-contact lithotripsy mode, keeping a low energy and high frequency, and mostly concentrated on dusting the stone part with this. So one by one, I went in different calyces to break the stone. This is the first stone which is being broken. Then I went in the another calyx. This is the another stone which is being tackled. I just went on dusting the stone, and the fragments were also taken care of. This is the third stone, which is also enveloped with the soft tissue and matrix kind of material all around, which was cut with the laser, and then the stone was dusted again. I used to vary between the frequencies as well as the energy settings in order to make my process efficient enough and fast enough so that the stone fragmentation or the time taken is less. Used to keep the irrigation, intrarenal irrigation flow at a very low pressure. Although I had kept a 12-14 French excess sheath, so that was there in the mind that the drainage of the system is quite good. Dusted the stone, and then at last I could see most of the dust was there along with this soft tissue like substance which was there, which was rolling around along with the dust into the system. Basketed it out as much as possible, although I could not remove this thing completely because it was present in most of the calyces, like the calyces which were bearing the stones. So could not remove out, but just took out few of them. With pop dusting and popcorning settings also, I I dusted the remaining part of the stone. This is the last one, the fourth one, which was the bigger one, which was around 12 mm to 14 mm size, 12 mm size stone. really large stones. The total stone load was around 4 centimeters. It was 8 mm size, 2 stones. One was 12 mm and there was around 8 to 9 mm. Then after dusting all the stones, I did popcorning into the calyces which were bearing the stones. Increase the energy settings and reduce the bit of frequency and did the popcorning in all the calyces. Navigated whole kidney, all the calyces to just have a check at the any of the leftover fragments. And as you said that sometimes a stone fragment or a stone can get hidden behind the golden sand. So made sure with it.
Since video is going on, only two questions. What are
Yes,
the
sir.
reasons of deciding RIRS over mini PCNL in such case? And second thing, this appears to be a part of the metric stone. And as you know that ESWL or any other method will not allow this metric stone to come out unless and until we do PCNL. So how you remove this? So these are the two questions.
Sir, the matrix which was enveloping around the stone, first I cut the matrix. The stone which was seen within that matrix was then dusted completely. And this part, the part which was seen rolling around along with the dust of the stones, I basketed it out as far as possible. And I just stented it because the ureter was quite dilated and wanted to wait for around 3 to 4 weeks for all these things to come out. Even I was just thinking if there is some fragment left over inside or something, then I can go for a second look also. But I did a CT scan after. So these are the fluoroscopic images in which just I take the pilot shots while breaking just to know the number of stones where I could. And this is the final view of fluoroscopic view after completely dusting. The stone were 4 in number. Stone density was around 900 to 1100 Hounsfield units. My flexi URS time was around 63 minutes and lasing time was 42 minutes in this. Check fluoroscopy and stented. Antibiotics were done and the patient did well. There was no fever or nothing, and then it can be discharged, was discharged on the first day. 4 weeks later on, I did a plain CT KUB as there were no residual fragments, no significant residual stone was there. So I removed the double J stent. Sir, your question regarding you wanted why PCNL was not done. The patient was, I had suggested him mini perk also, although the anatomy was a bit difficult for him, but and the patient was totally not for PCNL or any kind of surgery in that regard. So he was like totally on doing so. Proper consent was also taken for the staged procedures. And that is the reason why I went for an RIRS in such a large stone load with matrix stones.
Nanjappa sir, would you like to take the question?
Good presentation, Ravi. Ravi, do you think that even after a CTKUB in such a case, when there's a lot of pus flakes, did you send those pus flakes also for culture?
Initially, the first stage when I did, when I put in the scope and I saw the pus flakes and the putty kind of material with that rigid scope, I had taken the sample from the renal pelvis part also and sent it for culture. That was also negative. And before going for a second, also like main concern was infection lying within the stones and this thing. So did a culture back again also.
Okay, so do you do a relook or with the CTKUB being normal, you don't do a relook at all?
I relied for this patient, I relied totally on CTKUB. I didn't do a relook. If there were some fragments here or there or something or
No,
entangled.
I'm not worried about the fragments. The fragment could have been seen on CT, but because of these pus flakes over there, the flakes which are over there, these fluffy things, Sometimes have you seen fungal things over there inside the kidney, sometimes giving such a picture?
Yes,
Which
fungal ball can
doesn't
be
go
there.
off because the stent is there in place. So then you may go ahead. We had a bad experience recently. So that's why I'm saying that cannot be picked up on a plain CT sometimes.
Right.
So that could be one challenge which can come over there. Abhishek.
Sir, Ravi sir, one thing that happens when we use lasers in these cases, this matrix actually becomes like a chewing gum. Rather than disintegrating, it further worsens. What is your experience? This is what
See, it was not very typically like a matrix, because matrix is something very gelatinous kind of thing. What we see in matrix stones. Here it was more like a fluffy kind of, maybe some soft tissue, or initially when I did, I thought more so of, as Nanjapa sir said, I more thought so of a fungal element within the kidney. But that was also not there. So this was not a typical, you can cut it with a laser fiber and can see the stone lying within that envelope kind of thing.
So now you were forced to do a flexible in this patient, right? Did you have any cutoff in your operative time? Did you say that you could finish off in this much time, or you didn't bother about the time which you taken to do the whole procedure?
Sir, I would arbitrarily, this is the longest case probably I have done with the lasing time is probably the longest. I would take a cutoff of around 50 minutes or so, 50 minutes to 60 minutes, not more than that.
Okay. And you finished off your entire procedure in 50 to 60 minutes.
60 minutes, yeah, I could finish up. 65 minutes. 1 hour, 5 minutes. Lasing time was around 40 minutes.
Any post-op, any difference in care of this patient?
Covered with IV antibiotics, and most of it was routine. So I was lucky enough not to face any kind of problems with this patient in post-operative course.
Sir, I'll just read out the questions from the chat box. So the question was, what is the maximum size of the stone that can be managed by RIRS? And Ashit sir has replied to that people have done stag horns, and he has also done stag horns. So it is an individual thing, but 2 centimeters is a guideline thing. But with the modern technology, people are pushing the envelope. Ravi sir, these questions are for you. How would you follow up such a matrix stone? When would you do a repeat imaging, and did you do a stone analysis, and what would be your indication for stone analysis in this situation?
Sent it for a stone analysis because this was a recurring stone on that side. And for such matrix stones, I would like to follow the patient with ultrasound, serial ultrasounds, because CT won't be very much indicative in such scenarios.
Yes, and follow-up will be CT. And so timeline of CT, would you imaging after is what the
3 months and 6 months.
Okay, sir. I think the consensus would be that the follow-up scan, there should be follow-up scans. You can't leave these patients off.
Yes.
Sir, one closing thought on this particular case was that suction is a very effective tool.
Yes. Now there are access sheets available with suction. As I didn't have them, so I used a larger size, because with that irrigation pressures of even around 100 centimeters of water, I will achieve something intrarenal pressures of less than 20, 25, around 25. So that was the main intention, to keep a larger diameter access sheet in this case also. And I knew that the procedure will be a long time affair for me.
Yes, sir. Thank you very much, sir. Nanjappa sir, can we move ahead, sir?
Yeah, definitely we'll move ahead. One small thing, Abhishek, if you don't mind, I'll add again that we are talking of large volume. I think we are ending these 2 topics of large volume stones. So we should be very careful when we select large volume stones for flexible ureteroscopy. We should not just take the stag-on message of the stag-on that we can do a stag-on, because you will require multiple sittings to do a stag-on unless it is contraindicated to do a perk. But with the new technology coming in, with thinner scopes, with suction, as Abhishek put it, that's the wonderful thing which is coming in. Definitely we are changing our, that threshold of 2 centimeters guidelines only say so. With experience and things are going ahead, but you should know where exactly you're going to stop, because everything should get over in a single sitting, at least. Yeah, the pre-stenting thing is different, but at least in one sitting, you should be able to complete it. Staging a procedure to complete sitting and doing a stagger would not be a take-home message at this part. We may come to that part very soon with, suction and things coming in, but still at this stage, I would strictly say that we should not take that take-home message. Yes, Abhishek, continue, please.
Yes, sir. I agree with you 100%. Sir, moving ahead, we go to Dr. Sailesh Kamath, sir, for management of impacted upper ureteric calculus in a difficult ureter. Over to you, Sailesh, sir.
First of all, let me thank the West Zone Council and all its members for giving me this opportunity. I'm sharing my screen.
Good day, friends. I will be showing you management of ureteric calculus with a flexible ureteroscope in a difficult ureter.
Sir, please put it to full screen.
5-year-old gentleman presented with bilateral ureteric calculi. He underwent right DJ stenting. His left ureter could not be stented. This patient was posted for bilateral URSL with a semi-rigid 6 French ureteroscope. On entering the lower ureter, it was not possible to negotiate the scope beyond a few centimeters on both sides. Hence, decision was taken to use a flexible ureteroscope for management of this calculi. First, we'll see management of right ureteric stone, which is at the level of the iliac vessels. We start with endoscopic view of the ureter. You can appreciate the ureter to be inflamed and very difficult to negotiate. Now we can see the stone. The angle is quite difficult. Here we can see the stone moving with the pulsations of the iliac artery. Now we have to study the scope. To do that, I have placed the access sheet very close to the stone. After having a good control over the fiber, we start lasing the stone. We are doing it in the contact mode in this particular video. I am trying to go through the stone so that I get a good grasp on the stone with which I can push it back into the upper ureter, which is a straight part. Here you can see the stone being pushed into the straight ureter. In the straight ureter, it is easier to maneuver the scope and the fiber. All the time when we are firing, we are in contact with the stone. While lasing the stone, we need to have good control over the fiber. To have a good control over the fiber, we have to have a low power, and for that we do a low energy setting and we keep the frequency to a very low level, that is 6 to 8 Hertz. With patience, we break the stone to very small fragments. Once we are satisfied that the fragments are very small, we put a DJ stand and come out. After finishing the right side, we go to the management of left upper ureteric calculus. Here the stone is in the upper ureter, just beyond the PUJ. You can see this is a long-standing stone, the way it is impacted. You can see the mucosa overgrowing the stone, and there is prolapse of the mucosa, superficial mucosa over the stone, which is creating hindrance in our vision. constantly in contact mode, release the stone. All the time, we have to be in contact with the stone. We have to have good control over the stone. This is achieved by asking the anesthetist to give apnea when we are firing the laser. With patience and with meticulous work, we fragment the stone. Our aim at the moment is to achieve a through and through passage. Because once that is done, we can have our guide wire in place. All the time, we need a good vision. Good vision is provided by adequate irrigation. Irrigation should not be too fast as it will result in bleeding. And at the same time, if it goes into the PCS, the pressure in the PCS will increase and will cause leakage to the phonesis and sepsis. Finally, we have established a through and through passage in the stone. Now I will pass a guide wire through the passage into the PCS. Once this is done, we are safe. Here you can see us passing a guide wire through the stone into the proximal PCS. Now, if required, we can abort the case anytime and put a DJ stent in place. After getting the guide wire through, we removed the full assembly, went by the side of the guide wire and cleared the full stone. After 1 month, we did check URS. The right side was totally cleared. The left side, we were worried whether it would stricture, but there was no narrowing of the ureter at the site of the stone, and the edema had decreased significantly. Now, what is the difference between a rigid and flexible URS for treatment of ureteric stones? The tip of a rigid ureteroscope is easy to manage and easy to control. The tip of the flexible scope is difficult to maneuver as it is floppy. We cannot push stones with the help of a flexible URS into the proximal part. I would like to give a take-home message. Judicious use and proper placement of the access sheet is very essential. A general anesthesia is usually preferred in upper ureteric stones so that you have control on the movement of the stone. Proper control of the laser tip fiber by decreasing the energy and frequency and avoid injury to the ureteric mucosa.
Very good presentation, Sailesh. Very good presentation. I think you have
Thank you.
covered up the points. Yeah, really. All the points covered perfectly, beautifully. I think this is one indication where, we'll use a guide wire. We say a safety guide wire, vaparte ho ki nahi vaparte ho. This is the indication where a safety guide wire has to be used. So I think you took up the message very well, including your settings of your, they use a very low setting, low energy and low frequency, so that you don't damage the mucosa. Don't use general anesthesia so that you have very good control and not hit the mucosa. I think all the points were covered. So here, one point which I wanted to tell you is you said you adjusted the access sheet to near the cal. I didn't get that point. So what was that point? How did you adjust the access sheet to near the cal? What was that which you meant about saying? You used access sheet in both the sides?
Yeah, I use access sheet. First, I tried to do the right side without the access sheet, but unfortunately, I saw the stone, but I slipped out and then I could not get the entry again. So I used a access sheet even on the right side. Now I placed the access sheet very close to the stone. so that my scope would not slip down, because it was exactly at the angle. So it was a very difficult access. And on the left side, access sheet was kept at the level of L4, L5, so that my full flexible part of the scope is out of the access sheet. So I could maneuver it better.
Shailesh, one question that when you are not able to pass 6.5 French ureteroscope, then the larger size, access sheet, how you could introduce?
No, it was the angles. The ureter was dilated, but it was the angle which didn't allow me to put a semi-rigid scope inside.
Now, what Gaurav mentioned was wanted to tell you is he's asking you, the point is even placing an access sheet without a wire going up is difficult.
No. See, the wire went up to the stone.
So you use that to push your access sheet right in.
With that, I put the access sheet just beyond the stone first, and then maneuvered it down.
Okay.
So, sir,
on the right side, I could get the wire right into the PCS, because right was pre-stented.
Yes.
Left, I could not pre-stent also, because I could not get the guide wire through.
So you feel that without an access sheet also you could manage this case?
Which side you're talking about?
Any side, both the sides.
Without the access sheet, I would be able to manage it. But on the right side, I was finding it difficult to fix the scope near the stone. That is why I put the access sheet.
Okay.
So, sir, I wanted to bring about a point that it is critical to understand that the access sheet in these cases have to be used or not used discretionarily. Yes. There cannot be any particular rule. One important thing is that the flexible tip of the flexible ureteroscope is about 5 to 6 centimeters. So now imagine a situation where the stone is just above the pelvic brim. Then your access sheath has to remain in the lower ureter if you were to maneuver and handle the stone. But at the same time, when you only require a deflection of 5 degrees, 10 degrees, that is the situation where you can place the access sheath just close to the stone. It is like you are trying to use a semi-rigid ureteroscope, you flip it, you bring the 12 o'clock to 6 o'clock so that you get the angle of the laser fibers. The tricks that you do with a semi-rigid ureteroscope and you are not able to get to the stone, but you just need a slightly more deflection. That is the time you put the access sheath closer to the stone and garner this small deflection, and it will give you greater stability. Whereas when you need a little bit larger deflection, that is the time you have to get the access sheet to the lower ureter. Then only you can use the full potential of the flexible tip of 5 to 6 centimeters. Even in males, you may have to use a female sheath because you want to enter only into the lower ureter or just into the junction of lower and mid ureter. So this was one point I wanted to bring about. So there can be both the situations that you use the complete flexible segment of the flexible ureteroscope, or you just use only the tip of it to say get a deflection of 10 degrees or so, which Shailesh sir has wonderfully shown in both the situations. Once he needed only the deflection of the tip where he actually got the access sheath up near the stone. So that is what I wanted to bring about here.
So I think that's what the take-home message is, that everybody here has been commenting that a semi-rigid ureteroscope is much better to use in the ureter and maneuver than a flexible scope. So what you do is you convert your flexible scope inside to a semi-rigid one by using an access sheath. That's exactly you do in certain situations with a better tip deflection which you get. So this happens in both ways. So most important thing is we should use very low energy, because the energy is the bubble which forms. So the ureter is very important, so it doesn't hit the ureteric wall without you actually hitting your laser fiber on the ureteric wall. And that's the most important thing Shailesh has said. So I think, Abhishek, we can proceed with the next. Excellent presentation, Shailesh. Yeah, every point cleared so well.
Thank you very much.
Thank you, Shailesh sir. We move ahead with next presentation. I invite Dr. Kamlesh Maurya sir for his presentation on RIRS and CKD patients.
Hey, good evening, everyone. Just a minute. Is my screen visible?
Yes, sir. Slides are visible and you're audible. Please go ahead, sir.
Okay. Thank you. So good evening, everyone. First of all, I would like to thank Kandar sir and Gaurang sir for inviting me for this RIRS webinar. So I am basically more of a PCNL man than RIRS, just started doing it. So we had a case of a renal function deteriorating, and aim of the treatment for all the treatment is to have maximum renal function outcome and reduce complications. So PCNL, most of the time in CKD also we prefer to do a PCNL, but because of it has a high risk of bleeding. So in this case, RRS is least invasive, there is less chances of bleeding, and disadvantage that because of these are pre-stented patients, so they can have a higher chances of sepsis, but we can prevent it by doing a urine routine culture negative and starting antibiotics 1 day prior to RIRS. So this was my patient. He was 67 years old male who presented with raised serum creatinine 7.8 milligram and CT scan showed bilateral lower urinary calculus with left multiple small renal calculus. So we did a bilateral URS and plus DJ stenting, and the serum creatinine came down to 3.2. That was his baseline probably. So you can see this CT scan. There is multiple stones in left kidney. And because we thought that it might come down and block the ureter again, or creatinine may go up. So we thought of doing a RIRS in this case because of the multiple calyces, PCNL would have been difficult and it would have been much safer to do an RIRS than preventing a bleeding. So this is, you can see the stones are there. So these two stones we can see there is one stone hiding on the by side, and then we had few stones in the lower calyces. So because it was a pre-stented, so SSC could be placed very easily. And I started doing with I'm using bioradioscope, and I have a holmium laser. So with the holmium laser, I started dusting it. So try to start from the periphery and then go into the medial part. And as you can see, this it's not a very hard stone. House fluidity was around 800 or 900. So it could fragment very well. This is one stone in the calyx, other calyx. So we fragmented this both stones, then went on to the other calyces. So because there are multiple stones, so I was little skeptical whether I'll be able to do into all the calyces. And we tried, and we could do almost all the we can clear the stones. In all these cases, when I remove the DJ stent, I again recheck, do a scopy to see if there is any fragments remaining. Initially, I do dusting, and then later on, I do popcorning to break the stones into smaller fragments. So I try to do a small fragmentation, and if there are some large fragments which are not possible to do it, then we could try to engage in the basket and bring it out. But in this case, we could do a small fragmentations, very dusting fine. So we left it and put a DJ stent. So this was in the other calyx. It was little difficult because it was laterally placed. So but it started initially from the tip, and slowly as the stone fragmented, it again came out. And I'm not using much of the pressure, only with syringe saline, we are pushing this with the help of the 50 ml syringe. So RRS in CKD patient is safe and effective for multiple calyceal stones. So it causes less bleeding and we can do it. That's all. Nothing.
Good presentation, Kamlesh. That's a good thing. Can you tell me, do you use an access sheath in all your patients?
Yes, sir.
In this patient, did you use?
Yeah, we used to assess it, sir.
Did you have any criteria about the urine output of this patient, the volume of urine output to choose between fragmentation and dusting, or?
Means post-operative or pre-operative, sir?
Pre-operatively.
He had a good urine output around 1.5 to 2 liters a day, because initially when we put a DJ stent after doing URS, he had a good output and his urine, the serum creatinine also came down. Only our concern was that there are too many stones of 7-8 mm, so they can fall down again, block the ureter. And doing PCNL, I thought it may not be easy in going into all the calyces.
Okay, one small comment. When you had a problem about that lateral calyx entry, did you feel that if your working channel was in the other side, it would have been easier to tackle that stone?
Maybe, sir.
So just a change of the working channel would have made it that easier.
Okay.
Okay, and post-operatively, did you screen this patient with a CT before removal of your stent, or you did a sonography?
Most of the time, people here don't afford to do a CT scan. So what we have done is, when I do a RRS, so before removing DJ stent, I put them under anesthesia and just look into the calyces if there are any fragments remaining.
Okay.
Nanjapa, small comment. In a stone fest in Pune, in such a situation, a difficult situation when the stone is hidden behind the calyx, you know what they did? They put a guide wire, they coiled it inside that and multiple tucks and the stone came out. Perfect. So I think this is one of the tricks which I have learned there, and I will like to share it with all those who are doing RIRS.
Yes, sir. Wonderful. There are a lot of tricks of taking out your stone when the calyx is, when you can't reach it. Like you can even put your basket and you can try it out, or you can, as you said, put a guide wire. That's lovely to take it out, or change, just rotate your scope by 180 degrees. So your working channel comes to that side and you can easily laser the stone, or you can use your laser itself, the bubble of the laser, to just bubble it out of the calyx. Yes, Abhishek, your comments.
Kamlesh sir, has the incidence of hematuria been slightly longer in your case? Because I have experienced that the hematuria lasts for maybe a day or two more than...
in RIRS patient or in PCNL? Sir?
In RIRS. PCNL, of course, it comes.
No, for this case, it was not too much actually.
Okay. So that is something that I experienced and wanted to share. So in CKD patients, would you suggest that we chase all the smaller stones also, or just temper our aggression? Because some of them are actually, whatever you do, they are going to progress. Say the creatinine between 2 and 3. Whatever we do, actually merely stone removal is not going to stop his progression. At the same time, it may potentially give him a better dialysis free outcome. So where is exactly the sweet spot or a good balance?
Because his creatinine came down to almost 3. So we thought of removing all the stone, because if you look at the volumes, there are 4 or 5 stones. So that was one possibility, that they can come down in the ureter. Again, we have to do URS. So I thought that getting a stone free was much better. If it would have been 1, 6 or 7 mm stone, probably I would have left it as such.
Yes, sir. In your case, I agree, sir. Where it is easily accessible and where you can remove it, you should remove it. There is no question. Yeah. But there may be situations where you may not be actually, because these are small stones. When you've got the main stone out, they might be in corners. And are you wary of using energy close to the mucosa in these patients? Because they tend to bleed a lot.
Yeah. We try to avoid. But since I am not doing much of the RIRS. I just started doing 2 months back. So there are chances it's a little difficult to control yourself.
So I would say wonderful demonstration, sir. Yeah. Can we move ahead, sir?
Yeah, sure.
Sure. So, sir, we go ahead with the last presentation for the day, and it is by our sir. Kandap sir, would you like to introduce, or can I go ahead?
I'm not very sure whether Sung has joined us or
He's
not.
there. I can see him.
You see, you
I
can
am. I'm here.
Yeah.
Oh,
Hi.
fantastic, my
Oh,
dear
lovely.
friend. How are you? So,
Yeah,
it's a
thank you so
pleasure
much.
pleasure to introduce my dear friend Sung Cho. We call him Cho. His name is Michael, and so I recently came to know about this. And Cho, welcome to Urology Society of India West Zone webinar. And we are very happy that you could join in spite of your very busy schedule and your surgery also. Now, we are eagerly waiting for your presentation on robotic flexiureteroscopy, and he is going to talk to us about a Korean robo. I will not take much of the time. Robo, please, Sung, go ahead. Go ahead with your presentation.
Thank you for your introduction. So I share my screen. So can you see that?
Yeah, we see the screen.
Yeah, today I'll talk about the robot assisted RIRS, and basically this is based on some difficulties of the conventional practice of RIRS. So because we can consider surgeon's factor, patient factors, or surgical techniques and limitation of devices, as you can see the slide. So when surgeons may feel some muscle fatigue or some symptom like carpal tunnel syndrome and knee pain, and when you perform the RIRS, we can make some mucosal damage during stone fragmentation because of the respiratory movement. And basically some beginners may feel some difficulties when they do the basketing technique to remove the stones. And basically just some hospitals only can use only some low watt laser machine, for example. So we may feel a lot of limitations when we perform RIRS, as you can see this slide. So some people started to think about the new robotic platform to overcome this kind of limitations. So basically, the first robot the article was published in maybe just 15 years ago, and the name was Sensei Magellan, but we cannot see the machine anymore. But recently, you can see some robotic platforms named Avicenna Roboplex from Turkey, Ely Robot from France, and Jaminix from South Korea, and Monarch platform from United States. So this is a table to compare the specifications of these robotic platforms, but I don't want to see it in details. But basically, just the basic concept of these robotic platforms are the same. They have master and slave consoles, and master console would try to control the slave console remote with the the remote control. And this flexible ureteroscopy is attached to the slave console, and this slave console is right next to the patient's side, and the surgeons would control the master console, and the flexible ureteroscopy can be inserted through the ureter of the patients. And you can see the operating room, as you can see this slide, and there are basically so many people, but when we do the RIRS with this robotic platform, actually the assistant, we only need a single assistant to perform the whole procedures. And basically the distance from the master console and the slave console guarantee the less radiation exposure to the surgeon. So we don't need to wear the lead when we sit in front of the master console, as you can see. And the Korean model was recently approved in Korean FDA, and the second model is under registration. And maybe we can see it in Korea this summer, and maybe globally, maybe next year. And you can see some differences regarding stone fragmentation. The far left side video clip is showing the stone fragmentation by our one of our residents. And the middle one is as mine's stone fragmentation performed by myself. And the far right side video clip is the robotic RIRS machine during stone fragmentation. You can see the laser tip is just quite fixed in front of the stone, and just the stone fragmentation can be very just stable with robotic platform. And basically, I show this the video clip during the clinical trial when we made last year.
Your screen got logged out, Dr. Chow?
Yes, because I want to share another one. So can you see the video?
Yeah, we can see the video.
Yeah, actually, this is just when I am docking the flexible URS, and the flexible URS is being inserted into the ureteral axis, and this is the ureter. So I'll skip because of this video clip is 30 minutes. This video clip, so I want to skip from time to time. This, yeah, just this is the ureter stone. So now this I'm starting the stone fragmentation with flexible URS. And as you can see, the laser tip is quite fixed just in front of this stone. And recently, the robotic platform can merge some automated function. Basically, for example, to adjust the respiratory movement and some path recording function. That means that robotic platform can memorize the movement of the flexible URS to the targeted stone. And basically the only thing for surgeons to do is just press the button or the pedal to reach the targeted stone. And when we just reach the targeted stone, and then just we can do some stone fragmentation by laser or just grab a stone. I mean the fragmented stones. And now you can see the laser tip is quite fixed, and basically in vitro experiment is showing 25 or 33% stone increased efficiency of stone fragmentation time when we use the robotic platform. So,
Kandarp, can you mute the person who's Anu Jain? Just mute them.
In fact, I cannot because the control is not with me. I think Anu Jain is.
Yeah, thank you.
Yeah, okay. This is the stone fragmentation. I skip to 4. So now stones are quite fragmented. And the stones are fragmented. Then we can use the basket. Now I am changing the laser fiber to a stone basket. I wanted to remove the fragmented stones here. And basically with stone basket, surgeons may feel a lot of stress with a beginner assistant because they don't just move according to our surgeons intention. So basically with robotic platform, we can just control the basket ourselves. So just it can be quite effective. Just surgeons may control the stone baskets efficiently. Okay, this is a piece of video clip using I wanted to show some RIRS technique with robotic platform. So basically, when we use the robotic platform, we can imagine the value of using robotic platform regarding radiation-free procedure because of the distance from the master and slave console, and assist-free just during the stone fragmentation or basketing technique, and the cruise control function. Is mimicking the driving by just drivers, just adding the automatic functions such as path recording function or just respiratory adjusting movement of the robotic platform. So basically, when we are just familiar with the cutting edge technology of RIRS, then just with the robotic platform, we can imagine many different things from that time. So I'm anticipating the more increased efficiency of RIRS with the robotic platform in the near future. Thank you for your attention.
Thank you, Cho. That was a wonderful presentation. I think in this part of the world, we have just come out of the economics of flexible ureteroscopy and the digital scope. Now discussing about robotics in RIRS is still time to come. But I think with the, the technology getting so advanced and things becoming cheaper, this also is going to take a place. A small question to you. With the Avicina, the movements were all as we do with the scope. The console used to sit and used to move the upward and over with the right hand, and this movement was exactly the right and left hand was similar, simultaneous. Now with your easy uretero, the whole thing has gone to a gimbal. Do you think it's very easy to adapt to this gimbal and go over like the joystick? You take it over there and do it?
Maybe just they can provide joystick or some different type of handlers. And basically, I don't know the final version of the Zamenix, the recent name changed from Easy Retro. But basically, I feel the strong points of the new robotic platforms is that they improved user interface, because when I experienced the Avicina and the international symposiums, the user interface was not so familiar to me. So basically, they just modify some monitors and handlers regarding ergonomics for surgeons. So I feel this kind of just ergonomic things can be improved with the new robotic platforms. So. And basically, this robotic platform can use very different types of flexible URS, including usable. So maybe just the cost effective can be increased with some different kinds of adapters to use the different types of flexible URS. And basically, they are improving the ergonomics as well, including many different types of flexible URS. So basically, just surgeons may feel less discomfort, even the 5 to 6 cases of RIRS in a day. Because when I did the clinical trial, I did actually the 4 cases of RIRS for big stones in a day. But actually, I sat in front of the master console and I didn't feel any discomfort in my shoulders or arms. So I feel that is just one of the strong points of using flexible robotic platform for RIRS.
Dr. Cho, both RoboFlex and ILI, they don't control the baskets. So
Right.
this device controls the basket. I think that is an edge over the other competitors in the market.
Right, right.
So how
You
does
got
that
the point.
happen? Please tell us, how does that happen? Because our understanding is that there is one joystick which basically controls the shaft of the ureteroscope.
Mm-hmm.
Now we are talking about another device which is actually controlling the channel, the working channel, and it is also integrated onto the joystick. That is what I
Right. This is a good point. So there is a wheel just next to the button. And there's when we control this wheel, the basket can be controlled. So this is one of the important strong points of Korean robot platform. But I'm not sure this Avicina or Eli would adopt this kind of function using stone basket later in the near future. I don't know actually, but basically just we can control the stone basket with this Zaminix platform. And we don't need to get any stress with beginner assistance using basketing procedures. That's just one of the good points of using this newly developed robotic platform.
Another question regarding your platform is that the ORS device, now the J&J device, the Monarch has the ability to do a retrograde puncture. So that is going to be their USP. Because briefly we were working with Monarch. So does your robot in the current situation or in the near future is going to have a ability to do a retrograde puncture? Are you looking at that also?
Yeah, basically, I don't know the other companies, but I know just Monarch has a assisted puncture system, and basically the Monarch is well, I'm not sure whether the Monarch is a real robotic platform for RIRS. I feel it is for PCNL and ECIRS, but it is adopting the magnetic function for percutaneous puncture, and just with just advanced technology or advanced laser machine. Basically, many people think the future will be RIRS, and the cutoff size for RIRS can be increased using the increased efficiency, using the just new laser machine with improved efficiency for stone fragmentation. And just the area of RIRs will be expanded in the near future. So basically with this robotic platform, the surgeons may feel less discomfort, and we may feel the increased stone fragmentation efficiency, and the area of RIRs will be expanding. And basically, this company has this Korean company also considered adopting percutaneous puncture, the function for percutaneous puncture, but it is a matter of cost effective. But basically, the current model is only for RIRS. So do you feel basically just I am using the ultrasonography and fluoroscopy together for percutaneous puncture is very easy. And basically, after I make the percutaneous puncture with ultrasonography, and then we can use the flexible URS, a robotic platform. So, well, for medium size to big size RIRS, I think the RIRS robotic platform can work very easily. So the proportion of percutaneous puncture will be decreased in the near future. This is my guess. But basically, just we don't know the future, right?
Okay, so I think, Cho, very nice presentation as usual.
Thank you.
And for the viewers' information, Dr. Cho is a professor of urology at South Korean University. And he is a very eminent person in the field of endourology, and is a rising star actually in the field of endourology world over. And I have a pleasure of his company for a very long time, very recently at Nepal. And Dr. Cho is also very much involved into the research and this new Korean robo. So I think maybe we'll have a second generation of this Korean robo very soon, as he said. And we'll have a pleasure of his company of course, during our AIE 2023. So Joe, looking forward to receive you in Ahmedabad in 2023. An excellent presentation. and he won the first prize at during the EAU, recently concluded EAU. I think it's a video poster prize, sorry, the poster prize on this robotic presentation. And as we are discussing about the robo, and I will make a now very quick remark for every presentation because my moderators have done fantastic job actually. They've asked all the questions, nothing left for me to ask. So I have nothing more to comment also, but one by one, I will just go through it. First with the Cho, and I have pleasure of operating on Avicenna Robo, and the first generation as well as the second generation machine. The machine is bulky but good, no problem. And it, as Dr. Nanjappa said, that the right hand and the left hand both are doing the job exactly what we are doing during the procedure. The only problem is that you have to manually put the ureteroscope into the ureteral access sheath. That is point number one. I think that applies to all the robotic platform. But the basket manipulation is not there with that Avicenna Robo. That you have to do it with your assistant, like you use your assistant for the Da Vinci system. And now, so sometimes what you feel is that you need that robo only to make a fine dust. And the rest of the job, again, you have to do manually yourself. So that is a problem with the Avicenna. But as you said, that the surgeons ergonomics is also very, very important, and you don't get tired when you do many cases larger stone with the robotic platform. I have personally experienced it. So I think as the robo is the future, maybe in maybe after say 7-10 years down the line, I think all of us will be doing a robotic flexi ureteroscopy because robot is going to come. You can't stop technology, and it's going to come. So thank you, Chop, for this. I'll make a small, and I'm sure that you want to go to now AUA. Maybe tonight you are flying, or maybe tomorrow. And so Hiren, to start with you, excellent presentation on retained double J stent and how you managed to take it out. A very, very difficult job. And as you correctly use the escape engaged basket rather than using an N circle basket, because the N circle basket is very, very difficult to grip that double J stent. You have to break the stent into multiple pieces and grab it with the engaged basket. You can even use a Dakota basket also, but sometimes it's very difficult if it is retained or it's fit into the calyx, like in your case, very, very difficult to remove. Manually, it is very challenging. Experts can do this. You can use a flexible grasper also, available both with Cook and Boston. You catch hold of the fragments. That's fine. But one thing you said, Hiren, you are with us, right? Yeah.
Yes, sir. Yes.
So for the retained double J stent, you said that I think CT scan instead of plain CT. Now, none of us are doing the plain. Majority of us are not doing CT scan to review the position of the stent post-operatively. Most of the people rely on the plain CT, and especially when there are no much encrustation or stone formation. So when do you recommend CT scan? All the patients, or you recommend on a specific situation?
Sir, my comment was that in case of retained DJ stent, which is
so that is what I want to know. What do you call a retained stent?
When there is a significant stone burden, which should be assessed specifically by a CT, a stent which is forgotten more than 6 months or has come after years, rather than just doing a plain X-ray, the literature says that you should estimate the stone burden correctly with a CT. Plain X-ray can underestimate the stone burden, and we may think that we can go ahead and just get it out, but it may not come out.
So the point is that generally we recommend the double J stent placement post RIRS or post PCNL,
yes,
maybe for a month or 2 or maximum 3 months.
Not in those cases. So, in those cases,
so these are the cases where if you don't believe in getting a CT scan done, this may be perfectly okay. Not necessarily every case has to be. In my practice, I assess all the patients post with the CT scan.
Yes,
but it is not compulsory.
Yes,
but if you feel that if the stent is there for a very long time, in that case, I think you are better off getting a CT scan then, because most of us are taking out the stent under local anesthesia, and we try to pull the stent and it doesn't come out. Sometimes it may damage the ureter.
Yes,
that is one thing. And secondly, there was a question in the chat box. I see that when you finish the procedure in this patient, did you place the stent again?
No, sir. It was a nicely dilated ureter.
So you did not put the to struggle a lot while taking out the stent. There was your operating time was more. Still, you did not put the stent.
Yes.
Okay. Fine. So I think I'm done with you.
Thank you.
Ravi Jain, you presented a complex, difficult anatomy as well as in a very large stone. In
Yes.
fact, looking at your surgery, I didn't find that it was a very difficult case. You did it very nicely. So congratulations for that. But at the same time, as Dr. Nanjappa mentioned, IVU, most of us pre-operatively do not get a plain CT IVU before we proceed. We rely on plain CT KUB, most of us. As according to the EAU guideline, when you are planning invasive procedure, it is better off that you get a CT IVU done, but most of us do not get it done. And we rely on plain CTs. That time, you cannot get a proper idea about the anatomy of the pelvic alysis system. So, but IVU is also sometimes deceptive. And the comment was made by our moderators also that sometimes when you do RGP, the anatomy is totally different. When you go in, sometimes you find that though this was a very difficult, seems to be a very difficult case, but it turns out to be very simple. So sometimes you have to rely on the RGP or on table your finding. So do not solely depend on the IVU as mentioned by my experts. Now, Ravi, your stone had a 4 centimeter burden in all, I think, probably, if I'm not wrong. I think, so, and so you took this case because majority of the stones were small. That's why you ventured to do RIRS in this patient, or you think that any stone you can tackle? Do you really believe in the guideline of 2 centimeter stone? What is your take?
Sir, because the stones were multiple and were different locations. So if I had to do a PCNL and these were different small stones at various other locations. So that was the reason I planned for an RIRS procedure. Because if I had to do a PCNL, then I would have to make 2 punctures, especially for a lower calyx stone, something around 1 centimeter, different other locations. So because there were multiple stones at multiple locations, which looked to me like I could go for a staged procedure.
Okay, so in this patient, I think you are better off getting all the stones out at one particular go. And I think Dr. Gaurang Bhai asked about the question about the ECIRS.
Yes.
Now, in such a situation, supposing the stones are very small, you may do only RIRS rather than considering ECIRS. But if the stones are larger stones, in that case, or if there is a stagon stone along with a stagon or a large more than 2 centimeter size stone, and then there are stones in the multiple calyx, that time if you come do ECIRS,
yes,
that time I think you can be almost certain that you will do a complete clearance at one go. So ECIRS also has got its indications. In my practice, if the stones are very small, I do not do prepare the patient for the puncture. But if the stones are large size stone, I think you can do ECIRS. And generally people are doing, I don't have much experience of doing ECIRS. Generally, most of the people do a supine PCNL as well as the flexi-ureteroscopy. I have recently done a prone ECIRS where the patients were placed in a prone position, did a conventional puncture because I'm not very much versed with the supine PCNL. So Aditya made a puncture from above, and I did RIRS from below in a prone position. Of course, the patient was a female patient. There are 2 patients, and I think we did a very, very nice job for that patient. So I think I'm done with you, Ravi. And the last, so Ravi Nagar, he presented a multiple stones in the multiple calyx. So, and he correctly mentioned he correctly mentioned about the significance of the urine culture. I think it is very, very important that you get a urine culture done, and pre-operatively, if the urine culture is negative, I think probably it is a good idea to go. But in his case, if you could see that one of the urine culture was negative, there were lot many pus flecks around the stone. Whether it was a matrix related to it or it was there were the simple pus flecks. Ravi, what is your comment? Ravi Nagar.
Sir, actually, that was the thing. I repeated the cultures and again because took the sample at the first go also, and that was the only reason to stage the procedure also, because the thing in mind is always the infection bearing system. So once I was sure with it, with all counseling and consent, with a larger access sheath, low irrigation pressure, I had gone ahead with the RIRS procedure.
Okay, so sometimes, you know, even if the urine culture is negative, you will see this kind of picture, and especially if the stent is placed for a very long time. Some people have a habit of keeping the stent for more than 2 months, 3 months, thinking that it will produce a very good dilation, or maybe patient is waiting for the surgery. That time you can see such type of lot of pus flags in the kidney, even if the culture is negative. So it's not a very good idea to retain the double chest stent for a very, very long time. You keep the double chest stent for at least 10 days or 14 days maximum if you are planning a stage procedure. Now, in this patient also, I think ECRI could have been a better option, but your patient was not ready for a puncture. Otherwise, it was a very, very good option. And there were, if you look at the anatomy of your patient's kidney, the calyx were very much dilated. Maybe it was because of the previous pyelolithotomy which was done, so that there was a little bit of narrowing at the level of the UPJ that has produced significant hydroureteronephrosis. So all the calyx was very, very much dilated. So in such a case, if you try to fragment the stone, the fragment will fly from one calyx to another, and you will keep on chasing. So, and secondly, the very, very important in your patient was to produce a complete clearance. Otherwise, patient could have developed post-operative. I was thinking, looking at your first video, that this patient could have post-operative very bad course. But as you said that it was completely okay. Patient did not have fever, and there was a complete clearance which was produced. So excellent job. Regarding Shailesh Kamat's presentation, impacted upper uteric stone, always a challenge, whether to do a flexi uteroscopy or deal with the semi-rigid uteroscope. My preference, because when you say that the impacted upper uteric stone, it means that the stone can be from the level of the L to L5. That is by definition, that is the segment of the ureter. We call it as a upper ureter. The mid ureter starts from the upper SI joint to the lower SI joint. That is a mid ureter. But so in such a patient, supposing the stone was almost at the level of the L4, L5, if you try to put the ureteral access sheath, your manipulation in the ureter will be extremely difficult with this flexible uteroscope. So I think you have to first define where the stone it is. And as you correctly said, try to core the stone from the center to the periphery. When you try to do that, to core the stone from the center to the periphery, you will make some space, some amount of fluid will go in, and then gradually you go from the stone will shed off from the mucosa, and it will produce less damage. Impacted ureteric stone, chances of ureteric strictures are high. Maybe it is because of the impacted stone itself or laser-induced injury. So you have to be extremely careful using a proper laser setting, and especially when you are using a TFL, your frequency should not be more than 10, and total watt should not even exceed 10. So you use minimum energy to take a little longer time with the TFL, but you can do a wonderful job. So don't blame it directly on TFL only if you find a post-op stricture, because it could be because of the stone itself, which is very much impacted. So Shailesh, excellent job. And I think finally, Dr. Maurya's case, CKD patient and stones in the kidney, very, very sometimes difficult, challenging, and post-op course is also very turbulent. I have done some of the cases with the adult polycystic kidney disease, and this ADPKD has caused post-operative infection as well as the post-operative fever. So you have to be extremely careful about performing a procedure mainly in the polycystic disease kidney or chronic renal failure where there is a possibility of an infection. So I think most of the comments are made by my esteemed colleagues and moderators. Excellent job, Dr. Nanjappa and Dr. Abhishek. Congratulations, and all the speakers. Lovely job. We had a wonderful time. At one point in time, we had more than 92 people logged in. Right now, we have got 39 people. So I think it's time for all of us to have a nice day.
Yeah, Kandar. Yeah. On behalf of Council, we like to thank all the presenters for their excellent presentation and moderators for their inputs. The Council requests all the WestZone family members to participate in these monthly webinars. WestZone is by you and with you. So we want all hidden talents to get opportunity in WestZone meetings. So please share your work, feelings, and ideas to us. Dr. Kandar Parikh, me, and all other council members are always available for your comments. And please register for indoor conference. Thank you very much.
Thank you, sir.
Thank you. Thank you,
sir.
Kandar. Thank you, Gauran. Thank you for this
Thank you.
opportunity. Thank you,
Kandar
everybody.
sir,
Bye.
Gauran
Good
sir,
night.
all
Good night.
panelists. Thank you.
Bye.